Our next speaker is Dr. Abhay Moghekar, who's assistant professor in neurology at Johns Hopkins, and he has a very long interest in CSF leaks, and he also is the research director of the intracranial pressure abnormality group at Johns Hopkins. Dr. Moghekar?
Thank you, Dr. Shiving, and thank you, Connie, for giving me the chance to present some of the work we've been doing recently with regards to CSF leaks. We heard a lot about non-invasive methods about diagnosing them, but according to Willie Sutton, who kept getting caught because he robbed banks, they asked him, why do you rob banks? He said, that's where the money is. So we are going to go right to intracranial pressure monitoring because that's where the abnormality lies. And I'm not advocating it for everyone, but there's a role in a certain subpopulation of patients where the information from direct ICP monitoring can be really helpful. So I'm going to talk a bit about the ICP monitoring setup. We first started out doing ICP monitoring in skull-based CSF leaks and in patients with pseudotumor cerebri or IIH, and how we adopted that paradigm for patients with CSF leaks. And how can continuous ICP monitoring guide your percutaneous interventions when patients have failed multiple procedures. And throughout the talk, you'll see this interconversion between the units, because when we do lumbar punctures, the units are always centimeters of water, but just because of tradition and convention, when you do ICP monitoring, the units are always going to be in millimeters of mercury, and there's an easy conversion from millimeters of mercury to centimeters of water. We all know about the limitations of measuring opening pressure during a lumbar puncture. There's problems with positioning, there's known diurnal variation. A lumbar puncture gives you just a spot measurement of the pressure, but ICP varies quite a lot between the day and the night, especially all our pressures are higher at night, which has got to do with the supine position. We probably make more CSF at night, according to some MRI studies, and the effects of sleep-disordered breathing that elevate ICP even further at night. If you hyperventilate, you cause hypercarbia. It can falsely lower your ICP. And as everyone has heard time and again, pressures are often normal in the lateral decubitus position, but that's not surprising. Patients are not symptomatic in the lateral decubitus position. They're symptomatic when they're upright. So you need to know what pressures are in the upright position in this group of patients. Direct pressure monitoring actually started out before there were LPs, surprisingly. So, through trephine openings, these needles were inserted directly into the brain and pressures were measured in 1866. The Quincke needle was developed a bit later in 1891. So ICP monitoring precedes lumbar puncture pressure monitoring. In the 50s and 60s, the ICP was monitored with a graph paper, just like a continuous EEG would be, but obviously now we are a bit more advanced. The pressure probe is connected through an A to D converter. Sorry, let's skip that. We can go into the details of our setup later if you're interested. And then it's connected to a Power Lab data acquisition system that runs lab charts so that we can do offline analysis of these pressures. And those pressures are not lost like in the monitor and then they get lost, so we can actually do continuous analysis later on. We all know this chart. Dr. Friedman was instrumental in developing some of these guidelines. We know the criteria now, but these are, again, pressures in LP in the left lateral decubitus position. So this is what a typical tracing looks like, and I'm going to spend some time orienting you because there will be lots of graphs like this. So when we monitor ICP, we don't just record ICP, we record the heart rate and EKG. With plethysmography, we record their respirations, and with a pulse ox, we record their oxygen saturation, because you need multimodality monitoring to actually figure out what's happening to these patients. And as you can see, ICP is very pulsatile, and the first time you see it, it's shocking, because when you do lumbar punctures, you don't get much of that pulsatility because all the LP needles act like a low-pass filter and filters out those frequencies. But when you do direct ICP monitoring, you get to see this unfiltered version, and as you can see, it's very synchronous to the heart rate. And there's a background rhythm to it that's modulated somewhat by respiration. So ICP changes dramatically even over a time interval of a few minutes. And the pulse amplitude over here, you can see it goes from 5 to around 17, 12 centimeters. The pulse amplitude, not the pressure, but the pulse amplitude can be very high. So this is a trace over just 60150 to 602, so about 2 minutes. And we can compress our viewpoint so that we can analyze more of this data. So this is a more compressed viewpoint. As you can see, the EKG is compressed too. And again, here the ICP is pulsatile with the synchronous with the heart rate, but there's no modulation by respiration. Sorry. Okay. I'm not sure what's happening. Okay, there you go. As we do more monitoring overnight, you see these abnormalities in breathing. So this is a guy who has Shine Stokes breathing. As you can see, every time, sorry, this is probably advancing too fast now. I'm sorry, this is all out of sync. Yeah. I'm sorry, I'm not doing anything. Well, let's see if I can get back to the previous slide. Okay, this is a slide, right? Can we go from here? Yeah. No, this is fine. Okay, there you go. Thank you. So with changes in respiration, there's oxygen desaturation and pressures go up. So we can monitor all kinds of physiologic parameters. And this is a guy, as I was telling, who has Shine Stokes breathing. He had short hypopneic breaths and then deep breaths, and ICP gets modulated dramatically by your breathing. This is a person who had sleep apnea, and as you can see, when he's breathing normally and then he has an apneic episode or a hypopneic episode, immediately ICP starts going up, and the corollary is their oxygen saturation starts falling. So in people with sleep apnea, they have tremendous elevations of ICP throughout the night. This was a patient who was referred to us with severe headaches, no papilledema, opening pressure was normal, but when we did ICP monitoring overnight, over 8 hours, there were significant elevations in ICP. And as you can see over here, these pressure elevations go up to 40, 50 millimeters of mercury, which would be around 50 to 60 centimeters of water. And this is independent of any oxygen desaturation happening. So we know these episodes are not related to hypoxia or hypercarbia. Conversely, we also get a lot of patients who get diagnosed with IH without papilledema. They've had multiple shunts, nothing seems to work. They get referred to us, he had headaches, no papilledema, and it was a completely normal ICP monitoring overnight trace between 0 to 20. We have a pseudotumor cerebri center, but often we see more patients with pseudotumor cerebri. They don't really have high pressures. So then we adapted this paradigm to skull-based CSF leaks. And as you know, even skull-based CSF leaks, the vast majority of them are trauma-induced or accident or whatever. And they do fine, but the skull-based CSF leaks that are spontaneous are very highly likely to recur after surgical closure. And there's a common theme that they share a common risk factors. Both pseudotumor cerebri and spontaneous CSF leak patients have shared risk factors. So it's very likely that these patients started out with high pressures, and over time, the thinnest areas of their bone eroded, and that thinnest area is either the cribriform plate or the temporal bone over your middle ear cavity. And these patients will never manifest with papilledema because they will leak whenever their pressures go up. So these patients never get diagnosed as pseudotumor cerebri. They have findings suggestive of it, like a form fruste of pseudotumor, like empty sella on their imaging, but their pressures are going to be normal. They're not going to have papilledema as long as they are leaking. The moment you patch them and you repair them, their pressures go and the repair fails and they come back to you, right? So how can you capture this? So this is a patient with CSF rhinorrhea that we do pre-op ICP monitoring in them, meaning the day before they go for surgical repair, we put a lumbar catheter in their spine and do pre-op continuous ICP monitoring, and we capture what their baseline pressures are. So this person was normal, 0 to 10. Next day they go to the OR, they get their patch, their dural graft, bone graft done, and we continue monitoring for an additional 2 days. And what you can see, that same patient now has significant elevations in pressure. And we've done this in about 40 patients, and we published our initial paper about 8 years ago. About 25% of these patients, we immediately treat with Diamox. So you see high pressures, you treat with Diamox, you monitor an extra night. If pressures are still high, you keep going up on the dose of Diamox to up to 3,000. And if it controls it, that's what they get sent home on. If their pressures remain high despite 3 grams of Diamox, you get a shunt. And with this paradigm now, our risk of recurrent CSF leaks is gone down to 0. So now a baseline assessment involves you do a neuro-ophthalmology assessment, you do a lumbar puncture, you do a sleep study. Patients with skull-based CSF leaks, you cannot treat their sleep apnea with CPAP. They'll blow air into their brain. So you have a mandibular advancement device for them if they have OSA. And we do perioperative monitoring on all these patients. And again, we updated our results recently in this paper. So we decided to adopt this paradigm for patients with spontaneous spinal CSF leaks. But what are normal intracranial pressures when upright? We're not worried about lumbar pressures. We want to know what are normal intracranial pressures when you're upright, when you're most symptomatic. And this was the first paper to be published about this, where pressures were monitored, granted not in normals, but in patients who had some CSF disorder through a lumbar catheter as well as through an external ventricular drain. And at this point marked star, the patient sat up. And what you can see is when you sit up, the lumbar CSF pressure goes up and stays up, whereas the ventricular pressures, has a steep fall. There's a slight transient rise, but then it stabilizes, and if you look at it, below 0. So pressures relatively in your intracranial compartment fall below 0 in the upright position. Just like in LA, only 3 things matter: location, location, location. So the same thing with ICP monitoring. It's very critical to know where your probe is. Because if your probe is in the lateral ventricle near the foramen of Monroe, your pressures are going to be different than if you're monitoring it with a bolt, with a parenchymal transducer in the brain. This difference in height doesn't matter if you're lying flat, right? Because it's at the same level. But when you're upright, that 3 to 4 centimeters actually matters. And that's created some confusion in the literature when these different pressures are presented in the upright position. So this is a series that I could find in the literature who've done positional testing, the vast majority of them in patients, but as you can see, there have been some authors who have been able to get some normals. But even then, they're not quite truly normals. They are patients who had a small extradural meningioma that people thought would be unlikely to cause any ICP effects. And as you can see, initially the units were all in centimeters. More recently, units are in millimeters, and it depends what the reference point was, and that's why there's no uniformity to the number. But if you account for where the reference point is, and if you account for the units that are measured, it's simple. It all comes down to this number. So when you're upright, if your intracranial pressure is less than minus 10 millimeters of mercury, that's abnormal. When the monitoring is done with a parenchymal transducer in the convexity, not EBD, that number would change. So that's the absolute lower limit of normal in the upright position. This was a recent paper where there were many patients with hydrocephalus, IIH, NPH involved, but just focus on the data from normals. So this is normals when they are supine. This is normals when they sit on the chair. As you can see, it falls below 0. And this is when they were standing. It ranges from -10 to +0. So that's the range. -10 to +0 is the typical range for normal ICP in the upright position when being monitored in your brain. So we adopted this paradigm. We did a couple of patients who were referred to us for pseudotumor cerebri who didn't really have pseudotumor. And when they're supine, their pressures are like this, between 0 to 5. When they sit up, their pressures go a little lower again, and when they stand up, pressures go a little lower again. But they never quite cross the threshold of -10. So this is what a normal positional test would look like in somebody who is not leaking. And when the patient lies down again, pressures go back again to where they were. This is a patient who had classic orthostatic headaches, had no imaging findings of intracranial hypotension, meaning no patchomeningeal enhancement, no sagging, no pituitary enlargement, no venous engorgement. And as you can see, when she goes down from the sitting to from lying to sitting position, over a course of 60 minutes, her pressures start slowly trending down. These spikes that you see are motion artifacts. You cannot really have someone sit still for 60 minutes, so these are just motion artifacts when the patient moves. And the pressure stabilized at around -19 millimeters of mercury, right? So she clearly was symptomatic from intracranial hypotension, but was imaging negative. Another patient with severe orthostatic headaches, negative imaging again, but this time pressures were normal when we sat her up. We go through a special protocol now, where we have them lie down first, then we gradually elevate the head of the bed, first to 10 degrees, then 20, 30, 40, 50 degrees. Then we have them sit for half an hour and then stand for half an hour. And this patient's pressures never really went down below even 0. So this patient, even though she had classic orthostatic headaches, came to us referred as a CSF leak, really did not have intracranial hypotension. And this was her, again, her pressures sitting up in bed. This is a patient, again, who was referred to us, who had multilevel epidural blood and fibrin patches, still had persistent headaches, and again, with positional testing, her pressures were normal. We referred her to the headache center. She got Botox, and she was remarkably better. If we hadn't directed her that way, she would keep getting scans, keep getting patches. So here, continuous ICP monitoring was helpful to us in, directing her to get the appropriate care. This was a challenging patient who had multilevel perineural cysts. And in these patients who failed multiple patches already, there's no clear identifiable site of a leak. We do ICP monitoring around the time that they're getting their patch. So we do a baseline ICP monitoring before they get a patch. And as you can see, pressures sitting up around -14, -12 millimeters of mercury. There was no clear identifiable site despite DSM. So she just had empiric blood patches, and we continued positional testing and monitoring. Pressures are no different, -11, -12 millimeters of mercury. So we repeated an additional 2 levels, and third day, her pressures bounced back up to normal while sitting. So clearly, there was some help. It was helpful to do this continuous ICP monitoring to really know, are we actually affecting intracranial pressures with our interventions? Another patient, again a challenging patient, had been through multiple procedures. This was pressures, even while supine, they were negative. She had a significant leak. And day 2, after the patch, she had rebound hypertension with pressures going to 30 to 40 millimeters of mercury. So dramatic, immediate increase in ICP. She was obese. She had sleep apnea, she had all the risk factors you can think for intracranial hypertension, but she never manifested it before because she was leaking. But you fix the leak, and now all of the underlying ICP physiology shows up. And in fact, in her, 3 grams of Diamox was not sufficient, so she ended up getting a shunt. A little bit about skull-based CSF leaks. This was a 61-year-old rheumatologist who actually developed a CSF rhinorrhea, through the skull-based CSF leak. He went through a paradigm, but even after the post-operative monitoring, the CSF pressure was not significantly elevated. It was about 19 just for a very short duration. We did positional testing. He was fine. But in addition, we did head turning. So when head was neutral, pressure was around 15 to 23. But when he turned his head to the right or to the left, pressures go up to 30, 40, 45 millimeters of mercury. So why does head turning do that? Remember, when you turn your head, you squeeze your jugular veins either on the right or the left. So we figured we need to image his venous anatomy to better understand this. And sure enough, he had a significant bilateral transverse sinus stenosis. We did an angiogram. He clearly had a gradient. We did venous manometry, meaning monitoring pressures within the cerebral venous sinus system. And as you can see, before we put a stent in him, at the torcular, the pressures were around 40 millimeters of mercury, which matched very well with his ICP. And as you go distal from the torcular on both sides, in the distal transverse sinus, the pressure was around 25, 26 something. And after we put the stent, that gradient disappeared. So again, in this person, he had underlying intracranial hypertension secondary to bilateral severe transverse sinus stenosis that manifested with CSF rhinorrhea. He never really had papilledema, never had high opening pressures to begin with.
Were his headaches better?
Pardon me?
His headaches were better?
Yes. And so again, just the same description. We did not, so you cannot immediately do venous stenting in somebody who's just undergone surgical skull-based CSF repair, right? Because venous stenting, you have to put them aspirin, Plavix. So for 8 months, we controlled him with Diamox, and then after he underwent stenting, he's been in remission. And we just published a case series of about the first 3 patients that we did this recently. We've done ICP monitoring in about 10 patients with Tarlov cysts, and some clearly had low pressures, whereas in some pressures were normal. What are the implications post-treatment, right? You always advise people not to strain, and how strict should you be with your guidelines about not straining and bending and lifting and so on. This is what just a single strong cough does. Your pressures go up to 70 to 80 millimeters of mercury in your skull, just a cough. So, it's really important to be cognizant of, not lifting, bending, straining after you've had a patch done or repair done. This is a very interesting sub-study that we did where we checked, ignore the left side of the graph, just focus on the right side, where we checked pressures with patients lying on their left lateral position with a catheter and then lying prone on their stomach. And as you can see, in the vast majority of patients, the pressures go up quite significantly. In fact, about 1/3 to half the patients, the pressures cross the threshold of 25 centimeters. And that's why we don't like measuring pressures prone in radiology. We like to roll them over to their left lateral decubitus position and then check an accurate opening pressure. And Dr. Shiving, this may also explain why you're finding a higher incidence of your venous fistulas in the left lateral versus prone position. So there could be a biology behind it. This is just lying supine with head neutral and turning right or left, and you see this, again, significant increase in pressures because you're, again, probably compressing your venous system when you turn your heads. And again, to emphasize the importance of treating sleep apnea, because every time you have apneic or hypopneic episodes, your ICP goes through the roof. You get hypoxic, but it's not the hypoxia that's driving the ICP, it's the hypercarbia. We don't have a good transcutaneous CO2 monitor to capture that data. And again, another patient, oxygen saturation drops, becomes hypopneic, pressures goes to 60 to 70 millimeters of mercury, and this happens throughout their night. So you can imagine what the burden of high ICP is. And if you did this LP in the daytime, you would get normal pressures. Just yet another example. So there are some practical implications, for post-treatment. Address sleep apnea, body position is important, monitor for rebound intracranial hypertension, think about venous sinus stenosis. It's helpful in guiding the right treatment, but also in avoiding futile treatment if intracranial pressures are actually normal. It's not without complications, but thankfully they are not that dramatic. One patient had a superficial MRSA infection that she needed antibiotics for about 14 days. One person did have a seizure, a grand mal tonic-clonic seizure, likely related to placement of the probe. Again, it's well known it can happen, but just to give you an idea of what happens during a seizure, we happen to be monitoring ICP during the seizure. And you can clearly see the tonic phase when the ICP just steeply climbs to 80, 90, 100 millimeters of mercury. And once the tonic phase goes away, it comes down, but it's immediately followed by this clonic phase. And that lasts quite a bit of time, from 3:15 to around 3:25, 10 minutes. And you can clearly see the oxygen saturation signal goes away during this tonic phase because likely of hypotension, blood flow. So, seizures are bad for your brain. So I'd like to thank a really good group that we've assembled at Hopkins. We couldn't have done this without Dr. Luciano in neurosurgery, interventional radiology colleagues, Dr. Rao, who's a colleague of mine in neurology, and all the nurses who work with us for doing the ICP monitoring, which is technically a bit more involved than what they usually do. Thank you.